water-soluble fibers, especially the one which is found in grapefruits and oats, it have clearly shown by results and researches that it decreases the low-density lipoprotein cholesterol. As well as if you have two-thirds of your dietary fibers, the recommendation for the dietary fibers around 28 grams from the American guidelines. From wheat fibers, which is the water insoluble, it have a very good impact on decreasing the low density lipoproteins as well as the triglyceride. What about adding omega-3, which is the main topic of today? Omega-3 fatty acids in your diet. A lot of study shows that if you give high dose of omega-3 fatty acids from 6 to 12 grams, of course, under the supervision of the physician or the clinical dietitian, it shows a reduction in the serum triglyceride levels from 40 to 80%. Why 40 to 80? Because it depends on the patient's situation, whether he have any other kind of metabolic disorder. Also, dietary intake from 9 to 12 ounces of salmon each day, which gives you exactly the same amount, nearly the same amount of 6 grams per day of omega-3 fatty acids, which I don't think everybody can have a salmon every day. Maybe once in a week, twice in a week, but daily you cannot. That's why supplementation plays a role in that. When we take the omega-3 supplementation, where we will reach to having an anticoagulant effect and better tolerance with patients with glucose intolerance, and you have a very good results in the patient's cases of decreasing the low density lipoproteins. The omega-3 fact sheet. Now, the structure of omega-3, they are a type of polyunsaturated fats where they are good for our health. And this omega-3 plays a very important role in our body, help supporting the heart, the brain, and have also reduced the inflammation. We have it in salmon, we have it in green leafy vegetables such as kale, spinach, we have it in the nuts such as walnuts. And this omega-3 plays a very important role in supporting the skin, the eyes, the brain, and definitely decreasing the LDL and triglyceride. These omega-3 fatty acids, they are a lipid metabolism regulation decrease. They have a one carbon metabolism. This carbon metabolism was fructo 1 to 6 biophosphate increase. They increase the 6-phosphogluconase. Also, they have a role in the citric acid cycle, in the protein synthesis, where all of those increase and decrease in those chemical reactions which happen in the body goes to improve what? The carbohydrate metabolism, improve insulin sensitivity, which you have a better control for diabetes, improve dyslipidemia, which is our talk today, improve the protein synthesis, improve the oxidative damage. So it plays a major role in, and one of the things that I tell my patients before going into a diet, when they come to me, I said, let's start with something simple. Take vitamin D, take omega-3, take high fiber diet, and take magnesium. Come back to me after 1 month measuring your waist and tell me whether you reduce weight or not. And you do try it yourself. You will see that if you want to reduce a bit of kilos, just try this. Omega-3, vitamin D, fibers, magnesium, and of course you have to be physically active, not just sitting and eating. And tell Wafa said that. No, you have to be active as well. And come back to me and tell me whether you succeeded to reduce some kilos in a month, which is very active. Now, in 2021, there was a hypothesis mechanism of omega-3 polyunsaturated fatty acids that decreases the cardiovascular disease. This is a very latest study where you can see when you can Google the study and look into the study itself, it has shown when they take omega-3 fatty acids, an anti-inflammatory effect will decrease the C-reactive protein, the inflammatory cytokines, the synthesis of proteins, It had a very important role in the plaque stabilization effects, in the lipids effects, in the anti-thrombotic effects, in the membrane stabilizing effects, in decreasing the low cholesterol oxidation. It has a beautiful impact in everybody. And this is the latest in 2021. So it has an excellent results in decreasing the cardiovascular diseases risk. Now, in primary and secondary prevention, what is the evidence for the cardiovascular benefits of omega-3 as from dietary sources? You see that there was a large CVD's outcomes trial of a pharmaceutical drugs of a mix of chains of omega-3, largely EPAs and DHA, carboxylic acid, omega-3 CA, at 4 grams per day. With a similar entry criteria that reduced the IT trial, which was also discontinued earlier by the Data Safety Monitoring Board. And it shows that the evidence shows that whatever they have done, whoever have shown a constant first triglyceride, lowering the effect of at high dose from 2 to 4 grams per day from the omega-3 polyunsaturated fatty acids, of course, independent of the cardiovascular disease event risk reduction. And those are all the studies which support this trial that shows when you give omega-3, it have an excellent results on lowering the cardiovascular disease risk as well as lowering the LDL. Now, how much is enough from the EPAs or DHA? Now, make sure that first of all you have to read what you have to tell your patients to read whatever they are getting, and how much EPAs and DHA are you getting? Now, for example, a 1,000 milligram of fish oil of a soft gel refers to only the size of this soft gel, not the level of EPAs and DHA. So they have to know that if to avoid deficiency, they have to make sure that they are having 500 milligram EPAs plus DHA. For proactive support, they have to take 1 grams EPAs plus DHA. For high intensity support for cardiovascular disease, as we just saw the study previously, 2 to 4 grams of EPAs and DHA to support. And all that have an effect on blood sugar, health of heart, improving the mood as well, the memory, better motions, better slow signing of aging. It have a beautiful study. And among individuals for atherosclerosis cardiovascular diseases, should omega-3 fatty acids be given on top of the statins? This means the statement said the answer of this question is yes. You have to give because it shows a very good improvement in decreasing the high triglyceride as well the low density lipoprotein, especially when we give the pure EPAs. This omega-3 fatty acids plus the supplementation, because not every time you can have it from food or not enough food, or some people, they don't like having salmon, for example. So, but there's a different type of food that you can take. You can have it from the canola, soya, or soya oil, where we have, AL, as well as 3.5 to 4 grams of the baked or sauté fish, especially the salmon. You can have it from the flaxseed. You can, but of course, DHA or ALA or EPAs from different kind of food. That's why we always tell people you have to take varieties. Varieties gives you what you want, but a single thing that can give you one kind of the omega-3, like alinolenic acids comes from the canola oil, while the eggs, for example, choose the eggs that are labeled rich in omega-3, which you can find them a lot now in the market. They have a good DHA. The salmon have a good DHA. So you have to pick varieties if I want to reach to my target of omega-3. Also, you can see this kind of food combination, which have people were surprised when I told them you can have dark chocolate, you can have unprocessed red meat, and you can have whole fat dairy. This mixture together, this complex food matrix with high saturated fatty acids, still, when you have the nutrients in that, works such as the micronutrients, the probiotics, the phospholipids, it showed that didn't increase any kind of cardiovascular disease or as well as the diabetes risk. So new recommendations should emphasize what kind of food I should take, how I can take it. So maybe then I can enjoy my steak with no fats in it. I can have my chocolate with, but it should be dark chocolate. The combination is very important. So I have to sit with a very qualified clinical dietitian to teach me what kind of food I should take and enjoy it at the same time with no emphasis on increasing my cardiovascular diseases or diabetes. Now, add the sterols, esters, or the stanols, the margarines to the diet, which control the dyslipidemia. All plant food usually they have those sterols. This substance shows a very important, beautiful role in controlling the LDL. Eating the food rich in fibers, which you can see, lowering the cholesterol naturally. And especially if I reach to the target, which is around 28 grams per day from my whole meal, from those fibers, have a beautiful role in controlling my LDL. Now, adding healthy fats in our diet as well manage the dyslipidemia. There's a nice fats that we can have it from fatty fish like salmon, tuna. We can have olive oil. We can have canola oil, which is polyunsaturated fatty acids and monounsaturated fatty acids. As you can see, good fats and bad fats, where you can go for the good fats, avocado, which all reduce the cholesterol and the triglyceride. Now, again, we can go for adding low carb vegetables and whole fruits. Why is that? Because this low carbs fruits and vegetables, you must take them because they are having green leafy vegetables, peppers, onion. All this can manage the dyslipidemia because they are very rich in magnesium, they are very rich in fibers, and they can work on our GI system in a very beautiful way, where they have an impact in reducing the dyslipidemia or controlling the dyslipidemia. Similarly, for the whole fruits that have the full fibers in that, and avoid, of course, the refined white bread and the sugary food or the juices. At that sense, if I want to have a control in my dyslipidemia. Now, what is recommended? Now, if I want to control, besides adequate exercise, we recommend, according to the guidelines, to have a low-fat, low-cholesterol diet. And I will show now different types of diets. We follow the plates or that pyramid, which is specially made for high fats and dyslipidemia. But the plates is easier to explain. When I tell them half of the plate is fruits and vegetables, and more green, which is more fruits, and go for more green dark veggies, more orange veggies, more dry beans and peas. For the fruits, I go for the whole fruits, whole fresh fruits, not the juices. And of course, the rest half will be for grains and for proteins. And my dairy products are outside the scope, and I go for low fat or fat free diet. Easy to explain to our patients because it's the plate which you eat your lunch and dinner or breakfast, that similar plate. So you can just imagine half of it, and you can easily, of course, don't go for the Egyptian pyramid, because when I tell them have the plate, that means it has to be a logical amount, not vertical. It should be horizontal. And that's what we explain to them and show them. Plus the 150 minutes exercise per week. Now, when we want to enjoy, we tell them enjoy green leafy vegetables, limit the starchy vegetables when we go for the fruits and vegetables, when we explain the plate, I mean, we minimize any kind of processed foods, vegetables and juices, smoothies, because they are rich in calories and the fibers and the benefits are less. When we go for the carbohydrates and we tell them what, enjoy whole grain bread, enjoy cereals, enjoy whole grain pasta. I love pasta, so take it as a whole grain. Brown rice, limit the white rice. See, I didn't say stop it, but limit it because I can take more. Now, one serving spoon of white rice or brown rice, I agree with you. It have 15 grams of carbohydrate, 60 calories equivalent. But the benefits that have fibers that fill your stomach gives you the benefits that decreases the LDL. Minimize any kind of ice cream, donuts, or candies that have high sugars with less benefits. And not only that, it abuses your dyslipidemia and makes it worsen. When we go for the proteins, similarly, we enjoy the seafood. We enjoy fatty fish like salmon and tuna and mackerel, but grilled and cooked in, for example, with garlic and lemon, tasty and very nice. Limit the eggs fried, but you can take it as boiled eggs. Minimize the red meat, minimize the cold cuts, the processed, because all processed food, all processed meat, high in hydrogenated fats as well as saturated fats. Why should I take it from that if I can have more meat and enjoy my steak when it have less fat? Similarly, for the fats, I go for polyunsaturated fatty acids, as I said, olive oil, canola oil, flaxseed oil, shea seeds, all these have the benefits, beautiful benefits in our body. Look at this when we take whatever I have said, and then I go for and explain it to my patient. What should I tell them? I'll tell them your diet will have 65% less or plus or minus from your energy intake according to your physical activity, according to your age, according to your height. So I calculated total sugar from that should be less than 10%, but the dietary fibers should be more than 25 grams. As we said, it's recommended because it have an impact on your decreasing the dyslipidemia. For the fat, it should be around 30% from the total energy, but from that, saturated fat should be less than 7%, and Na6 fatty acid should be less than 10%, or equivalent trans fat totally zero, and the cholesterol should be less than 300 milligram if I want to control the cholesteremia. So what for that, what we will consume? More fibers from the whole grain, more fruits and vegetables, lean meat or fatty fish, and whole fruits and vegetables. So diet recommendations for the low density lipoprotein, when we talk about hyperlipidemia, which is that means the elevation of some of all lipoproteins, including the cholesterol and the triglyceride. So we have to go for controlling them by having the proper diet. So the American Heart Association recommended that limiting the cholesterol to 300 milligram per day for a healthy adult and 200 milligram per day for individuals with a high risk of coronary heart diseases, or if they have any kind of metabolic disorder such as diabetes. And when we go for replacing saturated fatty acids, we go for replacing them with PUVA, polyunsaturated fatty acids, which have a very good impact on their low density lipoproteins, triglyceride, as well as high density lipoproteins. We go for monounsaturated fatty acids, and we go for a good carbohydrates, which is the complex carbohydrates. And all these have an impact on decreasing the dyslipidemia and controlling the cholesterol level. So, what are the dietary factors that affect blood profile? When we talk about cholesterol, what happens exactly? When we take in food, cholesterol is the form of a free cholesterol or cholesterol esters, which is compounds made from cholesterol and fatty acids. These after cholesterol is ingested in the small intestine, the pancreatic enzymes cholesterol esterase the cuts of the fatty acids from cholesterol esters to what? To free cholesterol, which can be then, with the help of the bile acids, absorbed in our small intestine. Then what happens? Together, the triglyceride packed into the large fatty particles called the chylomicrons, where they enter to the lymph with the fluids within the lymphatic vessels, and then this cholesterol is absorbed efficiently among the different individuals from 20 to 80%, mainly depending on the genetic factors. That's why people, even they are thin, but they have the familial hypercholesterolemia. Why is that? Because this is the production for the 80 grams, while from food you get only 20% of the cholesterol. The recommendations for the practice to reduce the intake of saturated fatty acids, which the evidence-based rate that's less than 7%, as I just shown, increase the poly and mono fats, or replace them, stop the hydrogenated fats and reduce totally the saturated fats to less than 7%. Increase the soluble fibers, increase the intake of soya proteins, increase the plant stanol, and I show you the importance of sterols and plant stanols, increase the omega-3, and I showed that. And now I'm going to talk about following the Mediterranean diet, following the portfolio diet, and doing, of course, exercises, which all benefits and recommended for the hyperdyslipidemia. So I was just talking now from the beginning till now about diet and effect. Is it effective? Does really it have an impact? These dietary changes have shown to be the recommended first-line treatment for mild and moderate dyslipidemia. It is the first-line treatment for them. There was a meta-analysis that had been done for 37 mostly good quality control diet in the National Cholesterol Education Program for around 11,586 participants. The step one diet restrictions was intake for the total fat to less than 30% of the total calories, and saturated fat to less than 10%, and cholesterol 300%, which is the recommendation. The step two goal were to lower the saturated fat to less than 7%, and the total cholesterol for the 200 less than 200 milligram. Both of them have shown a significant reduction in total cholesterol, low density lipoproteins, as well as the triglyceride. Using soybeans, there was 23 good quality researches shown that if you use the soya protein, soybeans proteins with naturally occurring, that they have those naturally isoflavones, were significantly reducing the cholesterol, the LDL cholesterol, increasing the high density lipoproteins, and the amount of this soya isoflavones consumed varied across the studies. In the subgroup analysis, they showed that more than 80 milligram per day have effect on better lipid profile. And those subjects have the baseline of 240 milligram of total cholesterol, shown a greater results in the end of the study of decreasing the total cholesterol to less than 200 milligram. Also, fibers have shown the average dose of 9.5 grams were associated with statistically significant decrease of total cholesterol. We said the recommendation is 28 grams, but even if you go for the minimal dose, which is around 10 grams, have shown an amazing results in low density lipoproteins, but no significant results in high density lipoproteins or triglycerides, because only 10 grams were used. Now, this is a very famous diet for lowering cholesterol naturally, called the portfolio diet. It is a fair quality randomized control study with 34 participants. They participated with using the NCP step 2, the 200 milligram with less, just now I just said it, less than 7 grams of saturated fatty acid. But on those group, it shows that it markedly reduced the total cholesterol of LDL, but no improvement in the triglyceride or the high density lipoprotein. In this study, the first stage of this diet emphasized reduction of dietary saturated fatty acid cholesterol, and also the total, the LDL goal was not achieved as recommended. It decreases, yes, but it didn't show what the benefits which they aimed for, because it is, as I said, 9.5 grams only of fibers have been used, where the recommendation is more than 25 grams. Now, in portfolio diet for lowering low density lipoprotein, they have used the almond, which is 23 grams whole almond per 1000 calories. They have used the plant sterols, 1 gram, around 1 gram, again for 1000 calories. They have used the soluble fibers, I said 9.5, which is around 10 grams, soluble viscous fibers. They use the soya beans or the soya proteins, where around 22.5 grams. They consume the plant fibers in dried legumes, like 5 to 10 grams daily. But again, the target which was needed there for that diet was not achieved totally, but a little decrease was shown in all the subject, but not what the goal was or what they aimed for. My lovely Mediterranean diet, I love this diet for people who have for dyslipidemia, for people who want to reduce weight, for people who want to stay healthy. It's a beautiful diet. It's a beautiful balanced diet, and also very delicious one. You can eat everything in this diet. I did my master's degree on this one. The random control diet participated in this, shown a very beautiful reported show reduced the LDL among all subjects when they reduce the LDL, the Mediterranean diet. And the Mediterranean diet, you can see, you have to be physically active daily, which we all recommend. You eat as much as you want from fruits and vegetables. You eat twice a week from the fish and seafood, moderate portions of poultry, eggs, cheese, and the yogurt. You can have daily, of course, the water is must with all diets. In moderation, the wine, and it shows an impact and effect, as well as olive oil is added to that as a fat, and it had beautiful results. Considering also something
you have 5 minutes left.
Yes, yes, I need to finish. Considering a low glycemic index diet, this is a difficult one. You have to have the patient have a passion to know and to be taught this glycemic diet, but it have a very beautiful to show you what you should take. Omega-3, this is in 2021 also, the omega-3 fatty acids have shown a very important supplementation of gene expressions of inflammation. It showed that in that published random control studies, in all the studies have shown that it have a beneficial effect on omega-3 fatty acids in decreasing the inflammation, oxidative stress, and also have their effect on gene expression. The conclusion: let food be the medicine and the medicine be the food. What best than that? Enjoy the food. And management of lipids is a must. We have to make sure that we are having a proper diet to reduce the low density lipoproteins and increase the high density lipoproteins. We go for the portfolio diet, especially for vegetarian. It works because they don't like them. It have more plants. Mediterranean diet is my recommendation, and I love this diet. It has an amazing effect. The changes of cholesterol levels and the diets appear to be small, but it is, if you continue, it will be significant. It decreases the mortality rate, and it in all cases more significantly elevating level in nutritional supplements. We recommend exercise. We recommend having omega-3 fatty acids, vitamin D, water, as well as fibers, if I want to make sure that I'm reducing. My last slide saying that omega-3 fatty acids are known to play a role in the cardiovascular diseases, pulmonary immune. The three most studies shows that alpha-linolic acids and the APAs and the DHA have a very good impact on reducing the CVDs and coronary heart diseases. Omega-3 have suggested to lower the blood pressure, reduce the triglyceride, as well as development of the plaque of the arteries, and reduce the risk of arrhythmia, heart attacks, and stroke. With that, I end my talk, and these are my references. Thank you very much.
Thank you very much, Wafa. You're not only really an authentic leader, but you are also a super authentic speaker as well.
Thank you. Thank you.
The words came directly, from heart to heart and from brain to brain.
Shahada, thank you.
Thank you. And on top, you have stimulated our appetite with the pasta and the Mediterranean diet. So
it is an effective one.
Yeah. Speaking about the pasta, there is a message from Shabib Al-Kalbani. Thank you, Wafa. As usual, you continue to amaze us. So can you provide examples of whole grain pasta that can be bought from supermarkets, as this can be confusing? I know this is not directly related to the omega-3, but this is a very nice question to me.
Okay. Now, if you go, there is a pasta where we have. I don't know whether you have it in Oman, Shabib. First of all, بحييك. Second, I don't know whether you have it in the market, but we do have it. You go for a whole grain in the pasta. There's a brown one which is written whole grain pasta, and you can just read it and you can have it. To emphasize it, you can do a very nice recipes with that, with salmon, with mackerel, and you can add to that olive oil with a little bit vegetables, and you can have the best ever plate of pasta. Easy to do.
Excellent. Nuhad Al-Omari, thank you for your valuable lecture. What's your recommendation for pre-dyslipidemia, like cholesterol on upper borderline in general?
Again, for that, we have to go for, I advise them to go for the healthy plate, in that mixing the Mediterranean diet, because using the olive oil, which decreases the LDL, having high fibers, definitely, check the vitamin D, and definitely the omega-3 1000 milligram per day. This is the recommendation. Trust me, it works. High fiber, big salad, Greek salad, tabbouleh, fattoush, all kinds of salads where you can enjoy them, adding olive oil to them, plus your omega-3, plus your, especially the one who have high cholesterol. And one important thing, you have to be physically active. Why is that? Because it has been proven when you walk 10,000 steps a day, you are mopping away the LDL. So simply 10,000 steps a day with very good fibers, with the omega-3, with vitamin D checking and water, you will get to your reach of LDL. Trust me and do that and come back to me. Tell me what your outcomes. Yeah, Nuhad.
Excellent. A nice question by Yahya. Is there any guidelines that recommend to give pregnant women omega-3 tablets as a supplement beside the folic acid?
Well, Yahya, there is a new guidelines 2021 in the Canadian ones. You can go for that, and it is mentioned that yes, safely. First of all, omega-3 is from fish, but we don't recommend to have at the early pregnancy vitamin A, which might have a defect on the babies. But omega-3, if she is not a good eater, yes, it is safe to be taken. And you can go for the guidelines. There's a new guidelines. Actually, it's not a new one, but again, it has been implemented in the new guidelines of Canadian guidelines, 2021.
That's excellent. We'll take one more question, if you don't mind. Hani Muhammad, great presentation, Dr. Wafa. Should the use of omega-3 supplement be limited to patients with high triglycerides only and not high LDL, as there are some studies suggesting that omega-3 may have negative impact on LDL levels by causing it to raise?
Again, the new guidelines 2021 proven to be no, you can have the LDL, you can have the omega-3 and it have an impact on LDL. And I actually showed some of the slides in my slides. In the 2021, the omega-3 have decreased the LDL and have a good impact, not only on triglycerides, but also on low density lipoproteins. Even the sample which have used, they have used a very high dose of 6 to 12 grams, and still it didn't actually harm, but it have a good impact on the severe cases. So yes, you can have it, and it will have an impact.
Thank you very much, Wafa. It has been a pleasure having you. Thank you for sparing the time on a busy day and evening. And we hope to have you, to host you also in the future, if you don't mind.
I would love to. My pleasure. Thank you, everybody. Have a pleasant lectures. I'm sure you're going to enjoy the rest of the speakers. They are amazing. Good night and bye-bye.
Thank you. Good night.
Thank you, Dr. Hussam. Thank you, Ahmed.
Thank you very much. So if you are a licensed pharmacist and you want to grant the ACPE hours, the attendance code for this presentation is TXWK. TXWK, this is valid for pharmacists who are licensed in the US. And now it's my pleasure to introduce my brother and my best friend and our subject matter expert, Dr. Ahmed Al-Awaini. Dr. Ahmed is an American board certified pharmacotherapy specialist. He's currently serving as a clinical lecturer at the Gulf Medical University, Ajman. He also is a clinical pharmacist and preceptor for undergraduate and master in clinical pharmacy students at Thambay University Hospital, the affiliated university hospital with the Gulf Medical University. Ahmed is currently serving as the chair of IVPNAR Organizing Committee, leader of IVPN Journal Club Listserv. From August 2020 to August 2021, Ahmed worked as a cardiology clinical pharmacist at the Lebanese American Medical Center, Rizq Hospital in Lebanon. He was also a clinical lecturer and preceptor at LAU School of Pharmacy. Dr. Ahmed completed his Doctor of Pharmacy degree in 2019, followed by postgraduate Year 1 pharmacy residency in 2020 at the Lebanese American School of Pharmacy and Lebanese American Medical Center, Rizq Hospital. So over the next 30 minutes, Dr. Ahmed will be presenting, can you become an alpha with omega-3 fatty acids? Dr. Ahmed.
Thank you so much, my dearest mentor and godfather, Dr. Osama, for your kind introduction and giving this opportunity to present at this prestigious event. Along with Dr. Wafa Ayash and Dr. Osama Barakat in this interdisciplinary approach. Bismillah ar-Rahman ar-Rahim. So, my dearest audience, my presentation today will be about the potential benefits of omega-3 fatty acids with evidence-based, studies, and how for those who have the cardiac risk and established cardiovascular disease, how they can improve their health and protect from further damage later on. And that's when you become an alpha in terms of quality of life. So by the end of this presentation, we will be able to differentiate between the supplement versus the prescription omega-3 fatty acids. Also, we will review the literature and guidelines recommendation around the cardiovascular benefits of omega-3 fatty acids in all its forms. And finally, as pharmacist perspective, we will be discussing the main counseling points on omega-3 fatty acids whenever we prescribe it and dispense it to our patients, whether supplement or prescription, with a focus on the prescription. So to start with, actually, omega-3 fatty acids, the biological effects of those fatty acids. I will not drill into the the structure, the many of the nutritional values that Dr. Ayash has alluded to in detail, thankfully. So as you saw that actually omega-3 fatty acids have role as antiplatelets. They improve the myocardial function. They have anti-inflammatory effects. They have preconditioning. It was proven also in one study that it has preconditioning effects on the heart. And what we mean by preconditioning is that sometimes we induce ischemia preconditioning, short and repeated bursts of ischemia in a specific area in the coronary arteries in order to prevent further damage later on and having extension of the myocardial infarction. So it was shown to have those biological effects, and from that some studies, some of which you've seen with Dr. Ayash, that we have some sort of evidence about its benefit in heart disease, stroke, lupus, in cancer also recently. So there are many studies coming in. Some have neutral effect, some have positive, some have negative effect. So there is some conflicting evidence here, right? But what we will be focusing on in this presentation about the clinical benefits of omega-3 fatty acids. So you know that the main two forms and the one that we require from external sources are the eicosapentaenoic acid, which is the EPA, and docosahexaenoic acid, which is the DHA. So those are two forms of omega-3 fatty acids, and they are polyunsaturated fatty acids, which we call PUFAs, right? And they have been proven to have a preventive role in the development and progression of atherosclerotic cardiovascular disease, ASCVD. And also, more specifically, when we talk about the lipid profile, they have been shown to reduce also triglyceride level. And here there is rigorous research that we will drill into and dig deep into this studies to understand where do we stand and how we become confident when we recommend those products. This slide, I really like it because it summarizes the core message of this session. As as pharmacists and as healthcare provider, even as a nurse, as a nutritionist, even as a physician, we should be aware about the difference between prescription versus supplement, because there is a lot of ambiguity in the minds of the lay people, the public who are not medically educated. So first of all, the prescription omega-3 fatty acid, usually, of course, they are FDA approved, and they are in the form of ethyl esters, and we will see how that is useful in this form. And the content of the two major forms of omega-3 fatty acid is 90% of EPA, sometimes 90% of EPA plus DHA, sometimes only DHA. So it depends. Actually, there are many prescription products there, but the most important thing is that it's highly purified. There is no contaminants. Most of the content is actually EPA, DHA, which is the the true essence that will benefit our lipid profile and cardiovascular health. Okay, and also these two forms of omega-3, they are present in the form of ethyl esters. From a chemical point of view, these ethyl esters will make it hard to break. Longer acting, sustained release covers 24 hours. That's why usually we start initially to give this pill, the prescription, the FDA approved. This pill we give it once daily. Sometimes we will see as we move throughout this session, we can go to twice daily in the next step in the treatment, but initially once daily because it can cover 24 hours. And as I said, it's FDA approved in the US as it's a prescription medication, because as you know, usually FDA, they have little control on the supplements, as we will see. And it's actually officially registered as a prescription-only medication, you know, in the Gulf countries and many in the Arab countries, also in Europe, also in the US. It's officially registered as a prescription-only medication, and it's also, you know, covered by the insurance as well in the Gulf countries. Whereas when we talk about the supplement fish oil, which contains part of it is omega-3. Okay, so here is the supplement. So you can see the first difference is that the content is not 90%, it's only 30% comes, which is at its best. Some product also supplement, they contain 10%, they contain 20% of EPA and DHA. So this is the first thing. Okay, so then since it is less, you know, content of EPA and DHA, what will contain the remaining? Sometimes other oils, other vitamins, but also sometimes we have mercury and lead contamination. And this is something that can be dangerous for the health, as you know. And the chemical form for DHA and EPA, unlike, you know, the prescription where it was ethyl ester sustained release, here it is triglycerol. And from a chemical point of view, we know that triglycerol, it's easy to be broken down and, you know, digested. So it's rapidly degraded, therefore it is short acting. So one pill will not, you know, be sufficient. Sometimes you use it twice or 3 times as well, if you want to gain benefit. And since it's a supplement and there are mixture in the content, it's not actually FDA approved. It's used for general health. They will do and they will place many claims there. Some of them are supported, some of them are not. Some of them are based on case studies, not rigorously tested studies. And it's not registered, you know, in the Ministry of Health. It's registered in the municipality as a food supplement here. So it's very important that we put this picture in mind and how we simplify it to our patients whenever we want to explain, based on their characteristic, of course, and their, you know, comorbidities. So these are some of the labels which I'm sure all of you, you know, have seen those labels on different products, whether we are in the mall, supermarket, hypermarket, some in the pharmacy. So we see those products and we see those labels. For example, if you can look here in this, you know, nutritional label, it will tell you that this supplement, that serving size 2 soft gels, we have the fish oil that contains 360 milligram of EPA and 240 milligram of DHA. We will see actually that those content is very low to have the actual heart benefit, you know, as we will see in the study what doses they used. That's why it's a supplement, it's not prescription. Also, all of those, you know, supplement products, you will see that the label, they will tell you, and they have to put, for example, this statement has not been evaluated by the Food and Drug Administration, FDA. This product is not intended to diagnose, treat, cure, or prevent. So this is mandatory actually to put on any supplement, because on the supplement, they can put this, what we call structure or function claim. It's not, you know, an evidence-based healthy claim, etc. So that's why they put it on this supplement. Helps support healthy heart, etc. You know, many of those, you know, cholesterol-free, etc. Now, before we dig deep into the studies, I want to show you this slide, nice slide, because in order for you to know the rationale why, you know, the experts and medical community, they started thinking, okay, then because of this, we want to add something to statin. Actually, they did a meta-analysis of many different trials and registry studies, etc. And they found statins, of course, it's the standard of care, it's the gold, you know, and first-line treatment of dyslipidemia, post-myocardial infarction. It has multiple benefits, not only you know, reducing, you know, lipids, but also pleiotropic effect, anti-inflammatory effect, and many others. However, even when we add statin for the patient, the maximum percentage it can help is 50%, sometimes more. But there will be always some residual risk that is not solved by statin. Okay, and this is one of the main messages that also I want to share with you today. So having only statin on board for the patient will reduce the risk for sure, but not up to the 100% or 90%, or and even 10 or 20% reducing the risk is meaningful for the quality of life of the patient. That's why they started to look into complementary therapies, into more studies, more well sound and rigorously tested studies on some additional drugs, some of which was actually the omega-3. So we have what we call CVOT, which is cardiovascular outcome trials. There are a lot of cardiovascular outcome trials that tested omega-3 fatty acids in a variety of cardiovascular diseases. But we will go through these. Of course, these are, some of the studies that recruited the highest number of patients, and it was randomized, some double-blinded, etc. So they are really landmark, and they change practice, and some of them they led to the involvement of omega-3 in the guideline. Okay, so let's start with the first one, which is combination between Romantic 1 and Romantic 2. Actually, I combined them because they have very similar, population, intervention arms, and results. So those studies, they study the efficacy and safety of adding omega-3 fatty acids in statin-treated patients with residual hypertriglyceridemia. So we have a patient who is on statin, his LDL his LDL is controlled, but still triglycerides are not optimally managed. So they added omega-3 for those patients to see the efficacy and safety as well. It was a randomized, double-blinded, placebo-controlled clinical trial. So in Romantic 1, as you can see, actually the comparator was rosuvastatin 20 milligram, okay, which is, as we know, it's a high-intensity statin, whereas in Romantic 2, the comparison was atorvastatin 20 milligram, which is moderate-intensity statin. And in both of the trials, we used a combination actually of EPA and DHA in the dose of 4 gram daily. 2 gram, which means one capsule usually comes as 1 gram, so 2 capsule BID. Okay, so 2 capsule BID, 2 gram BID, that was the dose of the used omega-3 in those studies. And they compare it to atorvastatin alone or rosuvastatin alone. So the inclusion criteria is for those patients who have, dyslipidemia, where their LDL is less than 110, because as we said, they are on statin, so absolutely their LDL will be a bit controlled, but their triglyceride is above 200, from 200 to 500. As we know, usually our target for triglyceride is to be below the 150 milligram per deciliter. So the result actually came out to be promising. As you can see from the Romantic 1 result, we have seen that the effect on triglyceride goes in favor actually of omega-3 fatty acid, EPA plus DHA. And this was consistent among all patient group, diabetes mellitus, by age. So whether you have diabetes or not, by age, whether you are elderly, more than 65 or not, or by gender also, whether you are male or female. So all of them were clinically significant now and statistically significant. Now, the only exception was CKD. So when we had actually CKD, the difference was not statistically significant. So we can see again a more reduction in triglyceride in the omega-3 fatty acid arm. Now, when we look also into the non-HDL cholesterol, which is now becoming a very prominent, lab and surrogate marker in, the trials of dyslipidemia and treating dyslipidemia, we have here that the non-HDL cholesterol was improved by, again, omega-3 fatty acids. Also in the diabetes arm, in the CKD now, it's more significant in the non-CKD, as you can see, in opposite to the previous one, where it was, in the non-CKD, it was not significant when we talked about triglyceride. Also, it was significant in the female more, and when we talked about also those who are elderly. So combining those, two markers, the triglyceride and non-HDL cholesterol, you can see that in diabetes, it was, consistently, in this population, those who have diabetes, consistently, they have better results. Now, Romantic 2, also, we can see a significant reduction in triglyceride. As you can see here, it's 30% actually, whereas in the placebo, or in the other group also, where they had actually, sometime atorvastatin, right? It was a 5% increase. And here, you can also see the non-HDL was also significantly reduced. Total cholesterol, LDL was a little bit reduced, not much of extent like the others. HDL, it was increased, which is better also in terms of omega-3. We want it to be increased. VLDL also was decreased. So combining both actually studies, we can see that the addition of omega-3 fatty acid on top of atorvastatin resulted in greater reduction in triglyceride and non-HDL and other lipid and lipoprotein level. Now, to go specifically into the subgroup analysis, as we saw, the higher the baseline triglyceride, so we saw the range was between 200 and 500, but the higher the baseline triglyceride and the non-HDL level and the lower, BMI, the better the effect we will see. So these are some observations from subgroup analysis. And also with diabetes mellitus, those who have diabetes mellitus will have more noticeable, effect of omega-3 fatty acid on their lipid level. REDUCE-IT, the second trial, here it was also a practice changing, because here they studied only EPA, and the other name for it is icosapent ethyl, which is EPA. Only EPA they studied here for hypertriglyceridemia, for patients with elevated triglyceride on ischemic events. So as you can see, they enrolled patients with elevated triglyceride, cardiovascular disease, and on statins therapy. And they randomized them either 2 grams twice daily, as we said, 4 grams of EPA, or placebo in this case. And they followed up for the ischemic events and cardiovascular outcome. And actually, the inclusion criteria was for those around 8,000 patients with cardiovascular disease or with diabetes and other risk factors, okay, like smoking, hypertension, etc. They were on statin therapy and also elevated triglyceride levels, 135 to around 500. So almost similar approximately to the previous trial. So they were randomized again to these two groups equal. Now, the primary outcome you can see in the EPA group, the primary outcome happened only in 17.2%, whereas it happened in the placebo group 22%, and it was significantly, statistically significant. The secondary outcome, where we looked into, the cardiovascular death, non-fatal MI or stroke, also it was statistically significant, less in the omega-3 group. Therefore, the conclusion was that among patients with elevated triglyceride levels, despite the use of statin, when we add EPA on top of that statin, the risk of ischemic events was significantly lower. So that was, a practice changing. Why? Because the previous trial, Romantic, was only looking into that surrogate marker. But here, we are not looking only at the surrogate marker, we're looking at clinical effect, putting it into clinical scenario, ischemic event and death. So the third study is the EVAPORATE study. In the EVAPORATE study, they also studied EPA. It came 2 years after, REDUCE-IT trial. EVAPORATE trial, they studied the EPA on progression of coronary atherosclerosis in patients with elevated triglyceride on statin therapy. So it was a randomized, double-blinded, placebo-controlled. Again, they included those patients with 30 to 85 years of age. Triglyceride, the same level they included in the REDUCE trial. LDL was, between 40 and less than 115 because they are on statin. And their, as we said, their main objective was to evaluate the effect of EPA in adjunct to diet and statin therapy in patients with elevated triglyceride on coronary computed tomography CT angio plate volumes over 18 months, so over 1 year and a half. And we talked about the inclusion criteria. We just want to stress on something. The stenosis was here 20% or more narrowing in the plaque. And there were actually different volumes. We have low volume, moderate volume plaque, and high volume plaque. So the result came out like this. Actually, for the EPA, we used the 4 gram, also 2 gram BID daily. The primary outcome was in favor, in statistically significant manner, in favor of, the EPA omega-3 fatty acid. Change in the low attenuation, plaque, LAP from the baseline was less, minus 0.3. So it shrank in size, whereas it increased in size, this plaque in the placebo. Also, in the percentage in the total plaque volume was more significant in the omega-3. It shrank in size, by 9% less. It increased by 11% in the placebo. Also, the change in the non-calcified plaque was also in favor of the EPA. So the conclusion here was that EPA demonstrated, a part of the omega-3 fatty acid type, significant reduction of flap volume on the cardiovascular, plaque, this one, and on the expansion of this volume with the placebo when we compared it at 11 months. The last trial in our presentation is on the GISI Prevention trial, which was actually combining here. It's not only omega-3 fatty acid, but also it combined with it vitamin E, and they were looking into the myocardial infarction. In this case, the inclusion criteria was patient who, admitted with acute myocardial infarction in the past 3 months. They, actually distributed the patient between 1 gram combination of EPA DHA in this ratio, 1 gram daily of omega-3 fatty acid, and 300 milligram of vitamin E. Sometimes they are combined in one group. They are separated, so we have 3 groups, and then we have a placebo group. So there were 4 arms actually. The arm that showed the most benefit actually was the omega-3, whether it was with vitamin E or alone. We saw a decrease in the death by 15%. It was statistically significant, and decrease in cardiovascular death as well. But we did not see significant result in the non-fatal MI or stroke. But we saw, the significant result in the death and cardiovascular death. And these are some of the numbers that we have seen between the omega-3 and the control. Between those, arms, and the major one was in the sudden cardiac death, which it decreased by 45% in the omega-3 group. Therefore, now we can see in the patient leaflet in the omega-3 prescription, omega-3, fatty acid, when we have especially combined EPA and DHA, 1 gram per day can be given post-MI, and I have seen it in my practice on top of ACE inhibitor, beta blocker, high-intensity statin. We add this combination as well. So in the guideline now, in the European guideline, we can see that they recommend actually the use of fatty acid, omega-3 fatty acid in 2 to 4 gram daily. So we start with 2, and then we go up to 4 in hypertriglyceridemia to lower, triglyceride. Whereas in the American also Heart Association, in the advisory science report, also they add that whenever we have triglyceride level between 200 and 500, actually we can add 4 gram per day prescription omega-3 fatty acid, which will help in the, decrease in the triglyceride level, even when the triglyceride is more than 500, where we usually intervene with fenofibrate, etc. But we can add also omega-3 fatty acid in this case, and it was actually shown to be safe alone and in combination with fibrates. The last thing is that it's very important for us as pharmacists and healthcare provider in the clinics to let people know the difference between prescription and the supplement, and let them understand the appropriate indication for each dose. The MI is 1 gram daily, the hypertriglyceridemia 2 to 4 gram, and how to take the number of capsules from the prescription product, and to continue taking it with food, even if your triglyceride level is back to normal. And these are actually my take-home messages. Always the prescription omega-3, fatty acid is FDA approved and used in Europe for the treatment of hypertriglyceridemia. And prescription omega-3 fatty acid at 1 gram, we can use it in post-MI patients to prevent further cardiovascular events, and always enforce the adherence to the prescribed dose and continuity in your patient. And with that, I thank you so much for your active listening, and happy to take any question. Back to you, Dr. Osama.
Dr. Ahmed, very enlightening presentation. Thanks for highlighting on the difference between prescription and non-prescription omega-3. I learned a lot personally. That was really an amazing presentation. We have so many questions. We'll try to take a few. I start with a question by myself. Many patients come to me, Ahmed,
yes,
claiming that, I cannot tolerate omega-3 fatty acids. It has a fishy aftertaste. So the question now, after listening to your presentation, is it related to purification of the product? And, how we can select, the right omega-3 that has the least, least fishy taste and, very effective at the same time?
100%. Amazing question, Dr. Osama. Thank you. So, as you said, actually, when we said about the difference, between the two products, the more purified, the more concentrated our target compound, which are the pharmacologically active, EPA and DHA, the more we have of them, the less fishy taste we will have. Because in the other part, the supplement, when we have a mixture, only 30 or 20% of EPA, DHA, but more of the fish oil and all of the compounds that cause disorder, it will come more in the supplement, but less in the prescription. So this is something that is related to the manufacturing process. And yeah, I agree with you. In the supplement, this is something they see. What if they need to take it for a cardiovascular disease, when they take the prescription, they will see minimal of this bothering of this side effect.
Excellent. So for patients with reflux, probably we as a pharmacist, we should recommend the use of prescriptions omega-3 fatty acids. And this Ghattas Abu Dawood is mentioning that I guess we as a pharmacist, we should really raise the awareness about the difference between prescription and non-prescription omega-3 fatty acids. Sayyid Hussein is asking, could you tell us about the side effect now of omega-3? What if we exceed the recommended doses, or if we take so much of unpurified omega-3 fatty acid, what are the consequences?
Yeah, of course. Thank you, Dr. Sayyid. So actually, the most reported side effect in the literature is only GI side effect. That's why we say take it with food, usually to prevent those nausea, some vomiting, some GI, discomfort. I did not see, any serious side effect in my reading of those trials, even when they used, as Dr. Wafa mentioned, they reach 6 or 8 grams, sometimes 10 grams. There was no, safety issues. Now, mind you that we are talking here about the prescription. Now, when we talk about the supplement, you are right, because there are other ingredients like mercury, like lead. So here we need to be careful, not for patients to mix them. So for example, they will say, this is a supplement, it contains, let's say, 300 milligrams. So I can take four capsules, which is equivalent to, let's say, 1 gram or 1.2 gram, and then I will take it 8 capsules per day to compensate for the prescription. No, it does not work this way. Here we will find some toxicity from the other, ingredients, but not from the omega-3 fatty acid itself. So it's all about, the pharmacist who is counseling, and supplement. Take it if you want to take supplement, for general benefit. You can take it, but in very small amount.
And this will answer the questions of Iman and Ahmed, who's asking, does omega-3 cause arrhythmia, and is too much taking of omega-3 can increase blood pressure or bleeding? So by the evidence, those are not really established side effects.
Yeah, 100%.
Fikri Hussein is asking if omega-3 is beneficial more in primary or secondary prevention of ischemic heart diseases.
Yeah, that's a good thing, actually. So as we discussed, if you have a patient with, when we say primary, means we did not have yet an atherosclerotic event, clinical event. We did not have an MI or stroke, etc. So we can have patients who start with dyslipidemia, and we can, start them on top of statin, as we said. If their triglyceride level remain high, we can start them on, omega-3 fatty acid, prescription fatty acid. Okay. Now this is a primary prevention. So in the dose of 2 to 4 grams, we start with 2 grams per day. Now for the secondary, the second part of the question, yes, we can use it, as we said, post-MI. So in post-MI, but mainly it's better to use the EPA form, which is the one that was studied in 1 gram per day, of EPA. Here it is a secondary prevention, along with the standard, cornerstone therapy, as we said, ACE inhibitor, beta blocker, and high intensity statin.
Here, Maha Suleiman is thanking you very much for your nice presentation and interesting topic. Thank you again, Ahmed. Reem Abdulrab and Adil Muteri are asking about drug interactions. Is there any drugs that are really contraindicated to be taken with omega-3, like aspirin or anticoagulants?
Yeah, you can see, some case reports here and there, but in fact, I've been, in practice in the, anticoagulation clinic back in Lebanon, and we were seeing a lot of patients, on omega-3, while they are not only on antiplatelet, but also they are on rivaroxaban, on, warfarin, etc. But we did not see, any major bleeding events. So there is no really, established evidence about this interaction. No, you can give it actually safely.
Here, Farid Farhad is asking about the approval in pregnancy and if there is an established dose as well.
Yeah, so I will refer back to, as Dr. Wafa mentioned, it can be used in pregnant. Now, to tell the actual inclusion criteria in the studies, they did not include the pregnant women. Of course, as it's the norm for all prospective randomized controlled trial for ethical reason. But from what we know, that the only vitamin that is known to be teratogenic is vitamin A. The one that we try to avoid, as also Dr. Wafa mentioned, but this one is safe. Now, as for the dose, it will not really differ in terms of dose from the adult. 2 to 4 in hypertriglyceridemia. 1 is post-MI, in case the patient had an MI before becoming pregnant, but it will be the same. Pharmacokinetically, it's not affected in the pregnancy.
Here you have two greetings, one from Shahama Juma, a celebrity IVPNeer, amazing presentation. Thank you, Dr. Ahmed. And Thuraya Shimmari as well is shukran ala al-muhadara al-jamila ya Ahmed.
Shukran.
Hanan Salim will take the last question.
Yes.
Thank you, Dr. Ahmed, for this evidence-based presentation. Is there any evidence regarding using it in rheumatoid diseases?
Rheumatoid diseases. So when we say rheumatoid, we mean also the autoimmune diseases, those things. And I have mentioned actually in the biological effect slide that there is some data and some studies on its effect in lupus, SLE. This is part of the rheumatoid autoimmune disease. Yes, there is. The evidence is growing, Dr. Sahar, but still it's not in the FDA label or the EMA, the European Medication Agency label. It's not yet there. Even it's not in the off-label use. But there is a growing evidence in this area. And maybe in the next year, we can see some more practice-changing studies.
Excellent. Last comment that if omega-3 fatty acid is available as IV formulation, and I would take this question.
Yeah.
Yes, it is part of the new generation of IV lipid. It's added to promote the clearance of by the liver of the current IV fat, and to reduce and to be an immunomodulator at the same time with IV lipid. With this, I would like to thank you, Dr. Ahmed, for your amazing presentation. And if you are an American pharmacist again and you want to claim for your CME, the attendance code is TXWK. And many delegates are asking that they miss the first part of the presentation. So within a month's time, all of these presentations will be uploaded at the IVPN library in our website, so you can download the presentations, the slides, and you can view the recording as a YouTube. Now it's my honor and pleasure to introduce our last speaker for today's interesting session, Dr. Osama Barakat, who graduated from the Royal Free Hospital Medical School, University of London in 1999. Dr. Barakat underwent his internal medicine training at the University of Norfolk and Norwich Hospital, where he obtained his MRCP in 2002. Dr. Barakat took a post as a research fellow between 2002 and 2004 to study the prevalence and incidence of diabetic eye disease in the population of East Anglia, leading to his MD. He obtained a certificate of completion, a specialist training, CCST, in diabetes, endocrinology, and general internal medicine in 2008 at the Cambridge Deanery. His current post is a consultant physician, diabetologist, and endocrinologist at ICLDC Abu Dhabi. And no one is more subject matter expert and great speaker than Dr. Osama Barakat here, who is, for the coming 30 minutes, will be talking about dyslipidemia management, translating guidelines into practice. Thank you, Dr. Osama, for being with us tonight, and the stage is yours.
Thank you very much, and very nice for the nice introduction. And I really enjoyed the first two lectures. Let me just
take your time.
Just share my screen, and I think we can see it now. I'm very impressed by the first two lectures, so I just have to really thank them very much. I mean, so Simon, many thanks for the nice introduction. Really, what I want to hint out is how to, how to interpret the guidelines that have been published recently, and trying to go through them shortly and briefly, just for the sake of time. May I just remind everyone that actually dyslipidemia, it is a chronic disease. Because we have to remember, once you treat hyperlipidemia, it is a chronic disease. There's nothing called that I will give a lipid-lowering therapy for a few months and stop. There may be some special circumstances, but for the time being, dyslipidemia is a chronic disease. There are many risk factors that are leading to cardiovascular disease, and we have to remember ASVD is the major cause of death in the world. There are some modifiable risk factors like smoking, obesity, lack of exercise, bad habits, but non-modifiable risk factors particularly Asian family history, are very difficult to treat. And we all know that, if you look at the InterHeart study, looking at 30,000 people, you can see there's, probably 9 risk factors counted for 9 out of 10 of heart attacks. Smoking is really the major one. Now, is LDL reduction a hypothesis? It's really not a hypothesis. LDL reduction is important, and it's a fact that if you reduce the LDL, then you will get benefit. We know that if you reduce the LDL by around 1 millimole, you will get around 22% or 24% reduction in event, depending on the intensity of the medication that you're using. We have to understand lipid is not just LDL, right? So we have good lipids and we have bad lipids. You all know them, the LDL, IDL, and VLDL. And we know that, HDL really is something that we all would like to have a lot of, because really it's an anti-atherogenic lipoproteins. But, the mainstay of treatment remain an LDL reduction. Now, when we talk about targeting therapy, we all kind of rely quite a lot on LDL as a measurement, but one has to remember LDL by itself or lipid panel, it really should be all conclusive to look at other parameters, particularly triglyceride and non-HDL and HDL. But the priority to reduce cardiovascular death is really LDL reduction, if you look at all the guidelines. Now, is there a correlation between non-HDL and HDL in terms of coronary artery disease? We know if we have a lot of non-HDL, what's non-HDL is really everything, the whole of lipid profile minus your LDL, and that will give you non-HDL, which is really triglyceride and other lipoprotein and apoprotein and small dense LDL. So when we talk about, large number of non-HDL particles, we talk about a lot of coronary disease. The less of HDL we have, the more coronary disease we have. And we see this quite a lot in diabetic patients. We all know that, once you start to accumulate your bad lipids into the lumen of the artery, eventually you'll end up with a plaque which is very unstable, and it could be trigger and rupture, cause thrombosis and occlusion of the main coronary arteries. Now, where does the evidence come from in terms of cardiovascular prevention? So we know that lipid lowering, statin and other therapies are really the mainstay of management. But as Dr. Ahmed and Dr. Wafa spoke earlier, a healthy lifestyle, regular exercise, and smoking cessation, in addition to controlling other risk factors, are very important to the management of hyperlipidemia, in addition to cardiac rehabilitation, which plays an important role in psychologically and physically rehabilitating people who already have an event. Now, are statin beneficial in primary prevention? No, we know that from the old trials, the Jupiter, the CARS, the ASCOT, the WASCOPS, all the statins being included for many years in terms of proven reduction as a primary prevention. Moreover, secondary prevention, people who had an event, we know from the 4S, the CARE, the lipid, HPS, TNT, and PROVE-IT, all of these trials prove that statin plays a major role in reducing cardiovascular event or recurrence of cardiovascular events. Now, the big question always, who should be on statin? Now, it's tricky unless you practice medicine in the clinic, particularly if you do metabolic medicine, as we do in our center and other centers around the world. But really, if you look at the right-hand side, who should be on statin? Yeah, this is the main category, and this is really the published in the new guidelines back in 2018. People at age 40 to 75 have an isolated LDL above 190 milligram. You don't need to do any risk assessment. Those patients should be on a statin. People with diabetes at the age of 40 to 75, and you'll be surprised how many people of this do we have who have an LDL between 70 to 189 milligram per deciliter. Those should be on moderate intensity statin, or if they have an ASVD, they should be on a high intensity statin. So diabetic between the age of 40 to 75 who have an LDL above 70, ideally should be on statin. That occupies a big number of patients. Now, younger patients, 20 to 39, with long-standing diabetes, so type 2 diabetes for more than 10 years, or type 1 for more than 20 years, it is reasonable to initiate statin on these people. Then you come to the gray area. What's about those old people with diabetes above the age of 75? Should we treat them or not? Actually, the majority of those patients, remember we are aging population, and 75 isn't that old anymore, right? So if you have a diabetic above the age of 75, it is quite reasonable to initiate statin if they're not on it. But if they already have an ASVD or coronary event, and they are diabetic, and they are above the age of 75, you must continue treating them as if they are young. So you must carry on giving them high-intensity statin. So the guidelines now concentrate more on risk categorization and LDL target for each category. So basically, what you do in clinic, I mean, majority of our automated symptoms have some kind of ASVD or cardiovascular risk calculation. Now, those sometimes could be very misleading because you may have somebody with a low 10-year risk score, but if you ask the question, does anybody in your family have a heart attack? And you say, well, my mother had it at the age of 44 and my brother had it at the age of 52. Do you really need to be looking at risk calculation? No. So estimating the risk is useful, but sometimes could be misleading. And therefore, in the new ES guidelines, European Society of Cardiology and European Atherosclerosis guidelines, they put what they call risk-enhancing factors, particularly for primary prevention. So here we have somebody who hasn't had an event, who slightly has an elevated LDL. You should be looking for family history of premature ASVD. You should be looking for familial hyperlipidemia. You should look at component of metabolic dysfunction, metabolic syndrome. Look for history of preeclampsia or premature menopause. Chronic kidney disease is an important single risk factor for increased cardiovascular disease. Chronic inflammatory condition, HIV, psoriasis. South Asian, very, very high risk population. And if you had enough of clinical history, they can use a little bit of lipid biomarkers like CRP, lipoprotein little a, apoprotein B, or do something very simple in the clinic if you're suspicious of atherosclerosis, is ankle brachial index measurement, which is done by the nurse, non-invasive, it's costless, it costs nothing. You can do it in the clinic. Renal insufficiency has been recognized for the first time as being a major risk factor for increased risk of ASVD. And the lower the eGFR, the more likely that your patient will get a cardiovascular event. So here you don't have to use a lot of biomarkers, you don't have to use a lot of clinical history or risk enhancing or calculation. We know CKD by itself is a risk factor for ASVD. Now, lipoprotein little a is something that we use quite a lot in gray patients. So people who have slightly elevated LDL, you're not quite sure what to do with them. Maybe a family history, they don't have a lot of risk factor. So measurement of lipoprotein little a does give you an indicator for probability of further cardiovascular event in the future. The higher the lipoprotein little a, the more likely the patient will or might have an event in the future. So you can actually solely rely on a lipoprotein little a in kind of intermediate risk patient. Now, there will be sometimes as well when you want to give the patient statin, you're not quite sure, the patient is reluctant, the LDL is kind of, you know, above expected for his age, above expected for his health condition. They are quite reluctant to have a statin, and sometimes what we use is something called the coronary calcium scoring, which is really a non-invasive CT scanning that takes few minutes to try and see how many calcium deposits the patient has in their coronary arteries. It takes few minutes. You have to be expert to do it. You have to have a cardiologist and a good radiologist to do it. It takes probably a few minutes. What's tricky about it, that if you have somebody on a statin, you may get false positive results. And if you really score 0 on the calcium score, basically you don't need any statin unless you're a diabetic. You see how tricky diabetes could be. If you score between 1 to 99, then probably you need statin. Anything above 100, you should initiate statin. Guidelines for coronary calcium score. The guidelines does not recommend using calcium scanning in all primary prevention patients. So you have to minimize the cost and try not to overuse it. And you may use the coronary calcium score when there's a question mark about intermediate decision, as I explained to you. And having a positive calcium score at all may move that decision to a treatment. So it does help you whether you want to give statin or lipid-lowering therapy or not. Well, as I mentioned to you before, the 10-year risk calculation is just the beginning, because you can just start the discussion between the clinician and the patient, trying to identify the risk, get in-depth history of certain condition and the biochemical markers, and trying to explain discussion. Look, I've calculated your risk. It's around 7%. You are close to our mark. Your threshold is just 7.5, so you're only just below the margin. But you have a strong family history, you have an LDL that's persistently above 160 or greater, you have high triglyceride as well. I think we need to move forward, and I recommend that we use a treatment. So you can start the discussion and try and surround the patient by as many information as you have, as many probable risk factors as you can. It's just an open discussion, and most of the time you will succeed in initiating lipid therapy. The guidelines also recognize the intensity of the statin, and I think Ahmed touched on this earlier. You know, the higher the statin, the larger the LDL reduction. Why this is important? Because we know LDL reduction or ASVD reduction is proportionate to the amount of LDL reduction. In addition, if you have somebody in whom you want to reduce the LDL by 30 or 50%, then you know which statin or which dose to use. And therefore, after all of this, it came very important in 2019 to update the guidelines on lipid-lowering therapy to modify the risk of cardiovascular disease. And as I mentioned before, there's been major risk factors being added to the guidelines, additional risk factors, and non-traditional risk factors, as I mentioned before, like lipoprotein little a, inflammation, homocysteine level, and so on. But the major risk factors, we all know them: age, high LDL, low HDL, high triglyceride, diabetes, hypertension, CKD, cigarette smoking, family history. Those are the major risk factors you should be using to guide your treatment initiative. Now, what's important in the guidelines that they assign an LDL level to a certain category. But in addition to orienting us to use LDL, they've added a non-HDL, which is supposed to be no more than 30 milligram per deciliter to the target of LDL. And also what we added recently is ApoB measurement to patients with hyperlipidemia. But that really depends on the risk you have. So if you look at this table, it's quite a nice table. You go from the top for very low risk in yellow, where the desirable LDL level is 160 milligram per deciliter. Then you go to moderate level or moderate risk, and LDL 100 milligram or less, or you have a high risk patient, then you need an LDL of 70 milligram per deciliter. And if you have a very high risk patient, then you need a lower LDL. The lower the better, 1.4. And they've added a new term, which is not very English, but it's actually very, very high risk. So if somebody had an event and they went on to have another event in 2 years' time, then they require to have an LDL below 1 millimole or 40 milligram per deciliter. But you always have to ask your question. You ask yourself the question, if somebody had an event, why are they getting another event? Ahmed mentioned that quite nicely. Residual risk, something we have to look at. So how do we get LDL into target? We use high intensity statin. If that doesn't work, you add ezetimibe. If that doesn't work, you add a PCSK9 inhibitor. And sometimes you do all of this and you still have residual risk that you have to deal with. And therefore, the new guidelines recommended not only we measure LDL-C in all patients as a primary lipid profile, but triglyceride is recommended as a routine lipid panel for cardiovascular prevention. And non-HDL cholesterol evaluation is recommended for risk assessment, particularly in obese, diabetic, and high triglyceride, and people with very low LDL-C. Because remember, you will get those people with metabolic dysfunction whom they don't have a very high LDL, but when you look at high triglyceride, it's actually quite high. So Ahmed talked about residual risk. We know that, I mean, one of the meta-analysis that included, over course 1 million patients, 29 prospective studies showing that triglyceride level is a strong and independent predictor for cardiovascular risk. So do not ignore triglyceride. Do not just grant it the excuse of dietary involvement. Now, atherogenic dyslipidemia, and that's what we call, really, I would call it probably what very close to diabetic dyslipidemia, which really include, remember in diabetic, what they have a high fasting and postprandial triglyceride, they have low HDL, not very high LDL, but they have very high amount of small dense LDL-C. And this is the tricky lipid profile that you get with diabetic patients, where you could just may ignore the non-HDL by looking at LDL-C by itself. And we know from the DIASIS study that done in the Middle East, Saudi Arabia, Emirates, Lebanon, and Jordan, that despite statin therapy and high-intensity statin, that we still have high prevalent high triglyceride and non-HDL increase despite statin therapy. So it tells us that probably statin isn't enough in this population. And we know while statin reduce the cardiovascular risk, there's substantial residual risk. And this is another meta-analysis of 21 randomized trials, revealed that statin treatment prevented around 2 out of 10 major vascular events. But remember, there were still 8 events that haven't been prevented. This is being shown to you by Ahmed previously, and that's roughly the same. Now, you always get the case that, well, I have to increase the statin dose because I haven't achieved enough LDL reduction. And that's a very good example from the TNT trial, where the trialists have to increase or had to increase atorvastatin from 10 to 80 milligram in order to reduce event. They managed to reduce event by 2.2 absolute risk reduction when they went from 10 to 80, but they still left with 8.7 residual risk. It's all non-HDL and high triglycerides. Same, improve it, TIMI-22. You increase the statin dose, but if you look at the triglyceride at the bottom, the higher the triglyceride, the more, the higher the risk. But if you try and reduce your triglyceride, then you certainly get a reduction in event, which means a reduction in triglyceride will be translated into benefit. And I just wanted to have a look at this slide again. Look carefully for those LDL levels on the left. So if you look at the first one in red, LDL below 100 milligram, that's in target. Non-HDL above 130. Look at the green, LDL below 100 milligram, non-HDL into target. It means for the same level of LDL-C, you can have a different event rate. That means a high non-HDL above target will increase your risk by 32% for the same level of LDL-C. So do not just rely on LDL. You have a full lipid panel, you have to look at that. So for the same LDL level, you have different event rates, just simply because you have a high non-HDL. Now, what are the major lipid modifying agents? You all know it. We have the statin, the fibrate, the niacin, the omega-3 combination of APA and DHA and APA only. Now, if we talk about the omega-3 supplementation, you've heard quite a lot about it now. Does it have an effect in cardiovascular prevention? The mode of action being explained to you, or mechanism of benefit being explained to you by Ahmed. It's antiarrhythmic, improving myocardial function, anti-inflammatory, improve endothelial function, reduce triglyceride, VLDL. It has an antiplatelet effect. It has a good effect on heart rate and preconditioning, which is a very nice mechanism of action in terms of heart protection. Now, does the level of APA and DHA plays a role in cardiovascular health? We look at the graphs here that if you have low APA and DHA, then you probably have high mortality. But DHA is probably more consistent or consistently associated with lower cardiovascular mortality versus APA. But certainly, low level of DHA and APA does increase risk of cardiovascular mortality, or predict probably cardiovascular mortality in the future. You've seen this by Ahmed, the GESI prevention, that post-MI, the usage of omega-3, Omacor, played a role, particularly in reducing sudden cardiac death. This is another nice UK trial. It's a retrospective analysis, looking again adding the combination of APA and DHA post-MI, which is 1 gram daily, 90 days post myocardial infarction, and you can see that there was event rate reduction in favor of the arm of people who were put on Omacor, omega-3, APA, and DHA combination, which is really in keeping with the GESI prevention. So it is the question of dose, how many tablets do we give? Now, if you look at the first trial here, and here is adding the ADA, APA 4 gram per day to simvastatin, and you can look at the reduction of triglycerides. So here you have somebody on statin, and you add 4 gram of APA and DHA, and you get significant reduction of triglyceride. The same again, if you add APA and DHA to simvastatin, you get reduction in total cholesterol, VLDL, ApoB, increase in HDL, and reduction in LDL-C. So here you can see the metabolic effect of the combination of omega-3 and statin. The romantic, you've had it, so that's the addition of Omacor to rosuvastatin. Again, you can get the reduction in triglyceride, non-HDL, total cholesterol, VLDL, and ApoB. So the combination of omega-3 and statin does have a role in clinical practice. So what are the important implications for APA and DHA in measurement of mixed dyslipidemia? Most of the studies really show negligible change or reduction in LDL within 2 to 4 grams per day. Both speakers touched base about this before. A more significant and consistent impact is reducing atherogenic of lipid profile, because when you use the APA and DHA with a combination therapy, you're actually reducing your triglyceride, non-HDL, and more importantly, the ApoB, and improving the ApoB quality. So the impact on outcomes, we know from the REDUCE-IT trial and the JELIS trial. JELIS was done on a Japanese population with a lower amount of APA and DHA omega-3, where the REDUCE-IT mainly used a pure APA. And you can see both in JELIS trial in the Japanese population and REDUCE-IT that there is evidence for outcome for the addition of omega-3 fatty acids. So what does the guidelines really say about this? Now, we have to really look at the indication for the combination DAP and DHA. We would use it in post-MI. We've seen this in JESIP and the UK prospective trial. We use it in primary high triglyceride. We use it in post-myocardial infarction. Those are really the main indication for the combination. Now, there is definitely difference between prescription omega-3 and over-the-counter omega-3, and that's been discussed with you by Ahmed before. But the European Society of Cardiology 2019 guidelines stresses that, you know, if you have a high triglyceride, and look at the number, just over 200 milligram per deciliter, then you should consider omega-3, APA, DHA can be used as a pharmacological dose to lower triglyceride in 2 to 4 grams per day, which affects serum lipid and lipoproteins, in particular VLDL concentration. So they do recommend in high risk patients where the triglyceride between 1.5 to 5.6 millimoles, which is 135 to 499, and that's really based on the reduced design, that you can use omega-3 Omacor or pure APA with the probably 2 tablets of 4 grams of each to try and reduce high triglyceride in patients with high risk and metabolic dysfunction. And if you look again to the European Society of Cardiology, looking at the drug combination for the treatment of mixed lipidemia, again, combination of statin with the fibrate can be also considered while monitoring for myopathy because of risk of myositis, but the combination with fibrosis should be avoided. So here the guidelines kind of trying to push us towards using fenofibrate with a statin as the risk of myopathy and rhabdomyolysis is very little. And then if triglyceride not controlled by statin or fibrate, then a prescription omega-3 may be considered to decrease triglyceride further, and this combination are safe and well tolerated. And the recommended dose of APA and DHA to lower triglyceride is between 2 to 4 grams per day. Again, the American Heart Association, as Ahmed mentioned this before in his presentation, again, recommend the usage of omega-3, Omacor, and O-pure APA 4 grams per day to reduce the risk and triglyceride level and non-HDL in high-risk patients. So I hope we got this on time. So the take-home message, what we have to do is to focus on LDL, triglyceride, and non-HDL. Use the whole lipid panel. Consider fibrate or high dose, 2 to 4 grams per day, prescription omega-3 supplement to manage residual risk and high triglyceride. And you must manage other associated risk factors like smoking, obesity, hypertension, diabetes, and poor physical activity. With this, I would like to conclude my talk, and thank you very much for listening to me. Thank you.
Dr. Osama, thank you very much for this evidence-based rich presentation. That was very enlightening. I would like to thank you for your time spared with us this evening. We have a few questions. Anna Christina is asking, isn't it better to limit the production of supplement omega-3 fatty acid since it could be taken in the wrong dosage by patients, and at the same time, it is dangerous due to heavy metal contaminations?
I think those medication, omega-3, prescription omega-3 are medication, and they should only be prescribed with a prescription. Yeah, we should discourage people from using them over the counter, okay? Because they may have, if they're non-prescribed, non-prescription omega-3, they may have poor effects on health and outcomes. But particularly, as Wafa explained, Ahmed, Omacor is very safe medicine. But we should limit the dispensing of all these medication to only prescription.
Excellent. In the real clinical life, Dr. Osama Barakat, do you see, or what's the percentage of patients that develop intolerance, like nausea or reflux or tinnitus, etc.? What's your experience in this, and what is your, patient counseling in this matter?
Very interesting question. I mean, this is what you fear about when you see the size of the tablet. So you see it, it's not very high, probably 2 to 3% of our patients do have a problem with it. So the trick is, don't start with a high dose. Give them a week or two on 1 tablet, then a week or two on 2 tablets. And if the maximum they can what you have to concentrate is they have to tolerate the maximum and the minimum dose. So two tablets is the minimum, and 4 tablets, 4 grams is the maximum dose. If they're okay with just 2, then I will leave them on 2 grams, because even in the guidelines, they're very careful when they put 2 or 4 grams per day. They don't specify 4 grams. Yeah, and that's based on the Japanese population, but the Japanese population have a different APA level in the bloodstream, okay, and based on the tolerability and safety from the trial, right? So give them a week or 2 to swallow the 1 tablet, then you increase it. And if you want them to go to 4 grams per day, you can do it a week by week. The intolerance is very little, and they take it with food, no issue, none whatsoever.
Excellent. Good, nice question by Sania Mansour. She's asking about if there is any evidence of using omega-3 as an off-label use in ADHD in children's.
I think that's probably not a question for me. I'm not a pediatrician. Okay?
Yes.
So but there was a nice question from previously about rheumatoid arthritis, and I think I read one about ulcerative colitis. Okay, there's one publication from Sandra Paulo in Brazil back in 2016 about ulcerative colitis. Absolutely no evidence. I think more trial needed. The same for rheumatoid arthritis. Okay, we don't have enough evidence. Yes, they have some anti-inflammatory component in them, but to date we don't have any evidence. Now, for the pediatric question, I have absolutely no idea, so I can't comment.
Do you recommend, Abrar Al-Amri is asking if, omega-3 can be taken routinely by, all people, healthy people? Do you recommend low dose omega-3?
You want my opinion?
Yes.
Unless there's an indication, I absolutely do not recommend it.
All right, that's really fair. We have so many greetings from many delegates thanking you for your amazing presentations.
My pleasure.
Ali Al-Daggag, many patients, they have a fear of starting statin therapy. How would you able, to convince them that omega-3 is really indicated in their cases,
I think trying to persuade them to take a lipid-lowering therapy in this area is difficult. So if you Google, put LDL in vessels and go to images, okay, and show them how the plaque formed inside the vessel, you will scare them. And you will actually show them the facts. So I say, this is what's going to happen. Now, the problem, Osama, with LDL and triglyceride is people like subjective things. So people will feel high blood pressure and low blood pressure. They will feel a hyperglycemia, right? They will feel the chest pain. And LDL, non-HDL, is just a number with no symptoms.
Exactly.
Right? So unless you show them the IVS, the intravascular pictures, or you show them a cartoon of the plaque from Google, from anywhere, okay, and tell them that's what's going to happen. If you don't take your tablet, you're not going to persuade them. It takes a lot. I mean, now it doesn't take me a lot in clinic to persuade somebody to take statin or any treatment when it comes to lipid lowering, because now I've learned the trick. Okay, the moment they say no, I said it's fine, it's your decision. Go to Google, put LDL in vessel, put it in your favorite, click it, show it to them, and you will
Excellent. Excellent answer. I know you're not a neurologist nor rheumatologist, but people are still asking if there is a role of omega-3 in Alzheimer or in rheumatic diseases.
As I said, I don't believe there are enough evidence to support the indication. There are a lot of publications back in 2013. There's a couple about rheumatoid, about mental health, cancer, and so on. I don't think we have enough evidence to be able to recommend this.
I guess the same with COVID-19 patients, right?
Absolutely no evidence.
Excellent. So also they're asking about the memory function, also there is no evidence here. With this,
we know APA and DHA are good for the retina and for the brain, but I mean, there's no randomized control trial to support the prescription. That's what I meant.
Excellent. With this, we come to the conclusion, Dr. Osama Barakat. Really would like to thank you for your time and for your amazing presentation again. And we hope also to host you in future events, if you don't mind.
It would be my pleasure. I really enjoyed it. And for the first time, I sat listening to the first two lectures like a student. I really liked them. And I would like to thank everybody who took part, to thank Abbott, and personally to thank you, Osama, for inviting me. And we're not going to forget Ahmed Abdel Daim, I'm sure. He's showing now.
All right. Okay, go ahead, Ahmed Abdel Daim, Rida. It's now time for the Kahoot. Before that, let me remind you that if you are an American pharmacist and you want to claim for your ACPE, the code is TXWK. Ahmed, you know, the time is yours now for the Kahoot e-quizzes. Go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh, everybody. Thank you, Dr. Osama Barakat, for the greetings. I hope you enjoy our Kahoot as well. And, you know, dear colleagues, we start usually with, it's our pleasure. Thanks to our audience, to Abbott for this great event in collaboration with our beloved Gulf Medical University. Dr. Osama, you are here. So I like to abuse your presence if you respectfully allow us. You know, today we are talking about omega-3, and I think it's multidisciplinary practice and management. So I remember, Dr. Osama Tabara, the first email I got from you, I found something in the signature that is strength finder. I found five strengths about Osama Tabara. I still remember them: SS, AA, and F. Significant, strategic, achiever, activator, and futuristic as well. I witnessed them in IVBN network. So my question, by the way, I covered them. I went to take my first self-awareness training after I saw this signature. So my question to you, Dr. Osama, to what extent do you believe that it is important for a pharmacist, healthcare practitioner, or anybody in life to be self-aware? The floor is yours, sir.
Hi, Rida. You always surprise me with your questions. Truly not very prepared to give you the best answer, but you know, it's all about health, you know. And I always say, and I always mention that, you know, you are responsible for your own health. You know, you are, as a healthcare professionals, you control your health and you control your future. So, you know, without having a good health habit, you can never function and you can never be impressive. You know, with poor, unbalanced quality of life, you end up with sick calls, you end up with damaged punctuality, you end up with damaged reputation. So good health, you own it and you control it, and you become impressive accordingly as well.
Really appreciate the answer, sir. And you know, the reason I surprised you, because I believe you practice it. So I believe when it comes from heart, it reaches heart, and it reaches everybody heart. Thank you very much for being our host for this Kahoot lesson, definitely priceless lesson. That's which brings us to our pharmacotherapy course, which our dear colleague joined agent Ahmed Al-Awaini between IVBN and Gulf Medical University. It will give you multi-perspective, like Dr. Osama explained to us, how your self-awareness about health, about yourself can affect. Also, whenever you treat your patient, what aspects you should take into consideration. This is actually the essence, and this is the reason for which I personally took pharmacotherapy board. Make sure not to miss it and to access the link that was sent earlier in the chat by start of this event. Despite I was traveling and I am blessed to be back to Saudi Arabia and Medina al-Munawwara, I didn't have time to give my disclosures, but thankfully Dr. Osama put this nice flyer. I assure you it will not go out of it. Going to our new puzzle, as we mentioned, this is an arrangement question. You will have to arrange the answer according to the questions. So for such a question, for example, arrange in descending order. So the answer will be, you will drag the boxes to drag them up according to the right answer. So the right answer will be blue, green, yellow, and red. then you press submit. Or if you are viewing it from a mobile device, you will simply drag the boxes up and down until you get the right arrangement. Then you press submit. If you join us from a computer or a mobile device, simply please, I believe our sincere, just put the code for the game, the link, and yeah, it's now there. The link, you press it, it will take you to this screen. You will enter the code which is shown in the chat box. Then you will enter your email address with which you register to our activity. And finally, you will put a nickname, preferably your first and last names. Again, you will press the link and enter the game pin code. Then you will put the email address with which you register to our activity. And finally, you will put a nickname, preferably your first and last names. Please pay attention. In case you are one of the top 5 winners, you will receive an email within 2 days of today's event telling you that you are a winner and requesting for more details. So please make sure to respond as soon as possible. In another 2 days, if you do not reply, unfortunately, we have to move to the next winner. So we hope that you join our Kahoot winners screen soon. So it's time for fun, as well as learning in our nice Kahoot. So let's move on to our Kahoot screen with many enthusiastic audience. As I can see, as usual, they rush. You know, I like those who take the initiative to share the joy with us. We have been talking even before the event. It was really authentic and natural training session before our webinar today. So we continued it with the presentations, and we hope that you join us today to joy, learn, and win with our Kahoot.
But can you raise the music tone a lot, please?
Yeah, yes. So the code is 616621. Let's see, we have familiar name. I think this is our stellar Hiyab Shakaki, Muhammad Yusuf, Marina Zal. I like always to see, new faces. Remember, dear colleagues, Kahoot is about being knowledgeable, about being engaged, about being fast. It's actually a game live. Make sure not to miss its joy. Welcome everybody on board again. Just make sure to write down the code. It's 616621. Just write it down. Whenever, may Allah forbid, you got disconnected, just put the code again and you will get admitted to our game. Should we wait to 100 or hitting 90? Great. So 1 more minute, then we will go. Again, the code is 616621. 30 seconds more. Clock is ticking, life is ticking, and Kahoot is approaching. So starting our Kahoot again, just write down the code and join us. Even if you get disconnected, for the last time, it's 616621. Starting our Kahoot in 5, 4, 3, 2, 1. Let the fun begins. Thanks for connecting the evidence to the practice by our great speakers today. Here we go. True, false. Taking fish oil supplements is as good as taking them as drug. Or as eating fish, sorry. My lunch yesterday was fish, by the way. Fish and shrimps, very nice. It's false. It's never the same. Make sure to put in mind, let's see who was paying attention. Totally great name, except for Ghattas. Nice to see Ghattas, and I always like to see new winners. Prescription of omega-3 fatty acids are by our brilliant joint agent, interstellar Ahmed Al-Awaini. Brilliant presentation, brilliant point to put in mind whenever you're treating your patient. Thanks, Ahmed. Ghattas is doing great, dear colleagues, but it never ends. The last question. Optimal management of mixed dyslipidemia is thanks to the insightful, eye-opening actually presentation by Dr. Osama Barakat, sorry. Both Usamas are close to heart and mind, as well as omega-3 fatty acids. Statins plus omega-3 fatty acids is the right answer. And totally new names. I told you, dear colleagues, it's never ended till the last question. Fish oil is good for your heart because it thanks for those 13 loyal IVPNers or Kahutians, but actually they lower high triglycerides. And let's see, did anybody make a beat Ghattas? AD, welcome to the stage. Omega-3 fatty acid prescription dose is for high triglycerides. So you now know the main component and the dose as well. Thanks, Ahmed Al-Awaini, again for the insightful presentation. ED is making great job. Optimal duration of this dyslipidemia treatment is I think that Dr. Barakat clearly corrected a misconception about treatment duration. It's indefinitely. Make sure to put in mind whenever you encounter a patient with dyslipidemia, ED, I cannot believe my eyes, but Ghattas is after you. Watch out. Fishing industry in descending order from the highest to lowest. I assure you that there is no harm to try. Only 6%. I knew that it's not position, so just giving information. It's actually China, India, the Philippines, and Thailand. As you can see, welcome our Filipino colleagues. And no change as mentioned. I promise you, engagement question is very easy. It's supposed to be known for everybody. The host is Ahmed. Which one of the 5 Ahmeds that we have in IVPN? Oh my God, thank you very much. I didn't expect more than 50%, but all of them actually are great leaders. Ahmed Al-Touhi, our ambassador in Egypt, Ahmed Al-Awaini, our great presenter, and the lead of many activities, including our IVPN. And lastly, our great mentor, Ahmed Al-Dimandash, the lead of IVPN mentor. Congrats, everybody. Let's see who came to the top. Ghattas, hard luck, dear colleague. Did ED make it? Saeed Hussein Great job, Sayed. Who made it to the top? Donatel. The persistence and consistency. Congratulations, everybody, as well as the last two runners, Malak, and the fifth one. We will be contacted soon. Thank you for being with us in this insightful, beautiful evening.